Hello, everyone. I'm Dr. Jannat Riva. I welcome you all on the fourth and the last session on cardiology. So far, we have actually gone through the most important topic, which is relevant for the part one and part two examination. It does not negate the point that today's discussion is any less important. We will actually be recapitulating some of our learned, like theories in today's class, and at the same time I will be doing some like rapid online quiz at the same time, which I normally do during all my classes, like the ones before. At the same time, we will be going through some of the two-star important topic for cardiology, especially for part one examination, mainly focusing on the cardiovascular drugs and hypertension, and some of the like a little bit heterogeneous topic which cannot be put in under one umbrella. So without further ado, I will start my discussion today. But before that, I would just like to let you know again that cardiology is a very important topic for both part one and part two written examination. For in order to pass cardiology, you have to have a very sound knowledge regarding the ischemic heart disease, cardiac arrhythmia, heart failure, and then the remaining of the topic, like, for example, valvular heart disease and infective endocarditis and so forth. But these are the three most important topics for cardiology perspective. And you have to go through like every nooks and crannies of these different these three topics which I've just mentioned. You can expect around 2 to 3 questions, or sometimes even 4 to 5 questions from cardiac arrhythmia only, and definitely one question coming from the long QT syndrome. That is a very how do I say, like a very certain question that you will be facing in the part one examination. And you can expect around 15 questions coming from the cardiology. Sometimes the range can be within 12 to 15, or sometimes it can be a little bit more, such as 16 to 18 questions, which will be scattered across the both papers, paper A and paper B. All right. So we will start with a relatively less important topic for first, that is atrial myxedema. Actually, this is not a very common tumor. Heart is not, first of all, heart itself, it's not a common site for, like primary tumors, just like the brain. Because of the constant circulation, there is no transitional zone or something like that. For example, if you imagine the food pipe or the esophagus, you'll remember that the most common tumor originating from the food pipe is usually squamous cell carcinoma or adenocarcinoma, something like that. And that occurs because of the lining and the transitional zones particularly. However, in the heart, it's a relatively sterile zone, and there is always like blood circulation and high speed of blood circulation, which does not really allow the malignant cells to deposit, or, like there is no specific transitional zone where the cell lines can be changed into another dysplastic changes to turn into some sort of malignancy. So which is why heart itself is not a primary site for tumor. The only rare type of tumor that can originate from the heart itself is the atrial myxoma. However, secondary deposits can occur, although little bit less likely. Still, secondary deposits within the pericardium from other sources such as liver cancer or lung cancer, that can happen. Like metastasis can happen, but it's very unlikely, both for primary and the secondary malignancies. So now we will start with the atrial myxoma discussion. All right. So it's actually a benign tumor, first of all, and it originates, the location of this tumor is actually within the interatrial septum. Interatrial septum. So remember when I drew the diagram of atrium, sorry, this is a very clumsy photo. So this is basically the interatrial septum, and from developmental time, we know that the foramen, that is known as the foramen ovalis, this is located in the interatrial septum, but after the birth, it usually closes. So this, which leaves like a dentation in the interatrial septum, this is known as the fossa ovalis in the adults. So usually in fossa ovalis area, this atrial myxoma originates. It usually looks like a mushroom, looks like a little bit like pedunculated mass, heterogeneous pedunculated mass, and it has like a peduncle which attaches to this fossa ovalis region in the interatrial septum. So usually patients with atrial myxoma, they mimic the very the mid-diastolic murmur of a mitral stenosis. So you'll see that in mitral stenosis, the murmur that is produced because the blood flow is not proper while passing from the left atrium into the left ventricle because of the stenos valve, the murmur that is produced is known as the mid-diastolic murmur, or the MDM. So because of this pedunculated mass, it usually, like lies towards the mitral valve area, very close proximity, which is why similar mechanism will happen, like the blood will be not, accommodating properly from atrial contraction to ventricular dilatation during the from the left atrium to the left ventricle, basically across the mitral valve. So unlike the mitral stenosis, it will also additionally cause like a plop-like sound, okay? Because whenever the blood will be rushing and pushing the pedunculated mass across the valve, it will produce like a floppy sound. So sometimes some sort of click, like the mitral valve prolapse or a plop-like sound, can be, appreciated. But it's very difficult to do so in as an internist, but as a cardiologist, they have like a little bit more enhanced cardiac stethoscope along with phonograms and like advanced technology. Maybe with the help of that, you can clinically determine that. But it's very difficult to do it with conventional stethoscope. And in the normally patients with atrial myxoma, it's more common in female rather than male, and it can happen around in late 40s to 60 years of age. That is the normal age prevalence, but it can occur at any time of the age, basically. This is not like one of those liver cancer or lung cancer scenario where it will certainly happen in older generation. Not really. Among the young adult population, the prevalence has to be shown a bit more compared to the other population. And normally the symptom that usually a patient with atrial myxoma feel like is tiredness, fatigue, and palpitations. So palpitations and fatigability, these are the common symptoms. Apart from that, patients might be also presenting with fever, weight loss, some constitutional symptoms like anorexia. Sometimes clubbing is the late feature, or like it's a rare feature. Particularly if there is thrombus and vegetation dislodged from this mass and like being impregnated within the mitral valve, thereby mimicking the infective endocarditis. In that case, this type of clubbing, fever, and infective endocarditis like feature can actually arise. Apart from that, there are some of the complications. For example, it can also lead to, just like mitral stenosis, it can also lead to irregular heart rhythm, that is atrial fibrillation. Apart from that, it can also lead to systemic embolization and infective endocarditis and so forth. And in the echocardiography, usually like a pedunculated heterogeneous mass across the mitral valve originating from the interatrial septum is usually seen in the echocardiography. This is actually the confirmatory diagnosis. Treatment is usually surgical resection, but sometimes surgical resection is not possible because surgery itself has a couple of complications, and apart from that, it has a tendency to recur. So, however, we have to remember that surgical resection is the main modality of treatment. Okay. So let's see which of the in here you can see each of the following is associated with atrial myxoma, except for this. This will be the answer: J wave in the ECG, because J wave is seen in hypothermia. Apart from that, atrial fibrillation, mid-diastolic murmur, and clubbing, fever, these can all be present during atrial myxoma. So the most common site for primary cardiac tumors to occur in adults, the answer will be left atrium. All right, now in terms of the cardiac tamponade, basically it's a very easy topic. So I won't discuss much about this. Let me just write down. So basically what happens is that we know that imagine this is the heart, and this is invested by the visceral pericardium, and outside lies the parietal pericardium, basically. So in between the visceral and the diagram which I drew looks very big, but it lies in very close proximity. So it basically like the parietal pericardium moves in same, like there is basically not much virtual space in between these layers. It's just for diagrammatic and understanding purpose. So this is known as the pericardial space. We already know it from our basic anatomy class. So whenever there is like due to some pathological causes like any infection, inflammation, or any obstruction or malignancy, any cause that might be, when as a reaction, when there is fluid accumulation, it could be due to infarction, most common cause, that is an after a post ischemic heart disease attack. So what happens is this fluid collection takes place. This is known as the pericardial effusion. And when it reaches the maximum capacity, putting pressure on the, like overall heart itself, thereby reducing the cardiac output, and the heart is not able to move freely in that case, and not able to pump properly, at the same time not able to feel properly, feeling properly. So that is known as the cardiac tamponade. So cardiac tamponade is a medical emergency, and it actually, if not treated, or like surgical steps are not taken appropriately, in that case patient might even eventually die. And because the cardiac output is severely affected, so it usually leads to cardiac tamponade, usually leads to hemodynamic instability. So some of the common causes behind the, in our country's perspective, number one cause for cardiac tamponade is actually pericardial tuberculosis. This is more common than you can think of. And there are other causes like certain other infection like viral infection, bacterial infection, Lyme's disease, parasitic infection. And it could be due to some inflammatory conditions such as rheumatoid arthritis, SLE. It could be post-MI changes and all these things. But in our country's perspective, pericardial tuberculosis is a very important cause. And in terms of cardiac tamponade, of course, what will happen is the patient will be presenting with shortness of breath and chest pain. These will be the most common or vivid symptoms of the cardiac tamponade. Apart from that, patient might be presented with fatigue, palpitation, cough as well, but that's a late feature anyway. And shortness of breath and chest pain, these are the common symptoms. And in terms of the clinical signs, that is important. You might get the pulse might be tachycardic, or bradycardia might be present. Blood pressure is usually less than 90/60. So that is the parameter of hemodynamic or instability. Or patient might be already in cardiogenic shock in case of a tamponade. Temperature might be normal or maybe raised. And in the patient's JVP, this is actually more important. So JVP is usually increased in case of a pericardial effusion. So what happens is, because the overall venous return is increased, and thereby putting pressure over the right atrium. So all right, and JVP is increased. And another one is in case of precordium auscultation, what you can get is heart sounds can be muffled. So that occurs solely because the cardiac output is entirely lost. That's why heart is not able to pump, and thereby the heart valves are not able to close properly, thereby leading to muffled heart sound. In case of a chest X-ray, actually, if the background is beside this is constrictive pericarditis, so normally you can see the pericardial calcification, which is visible in the chest X-ray. Apart from that, cardiomegaly can be present, but normally in cardiac tamponade there is no calcification that you can see in chest X-ray. Cardiomegaly, that you can find in the chest X-ray. Apart from that, normally chest X-ray is usually normal. And ECG would be very much similar to the pericardial effusion. There is electrical alternance, which I have previously described in my previous classes, that basically the height of the R wave will be different in each of the leads. So that is electrical alternance. And the other one is the ST segment elevation, saddle shape, or concave upwards. That type of ST elevation usually takes place, ECG. If there is any other arrhythmia, that can be also picked up on the ECG, or the axis deviation, it can also be picked up on the ECG. Echocardiography, the pericardial window will show fluid accumulation in between the layers of the pericardium, and the ejection fraction might be too poor, left ventricular ejection fraction. So these are basically the diagnostic modality for pericardial tamponade. Treatment, of course, is you have to draw the fluid out. So this is known as pericardiocentesis. So this is it requires highly skilled cardiologists to do this pericardiac synthesis, because it's not like the ascitic fluid tap or pleural fluid tap. Lots of complication can arise, and that's why it should be done within the CCU or ICU setting with the patient cardiac monitoring and under an expert hand or skillful hand. And a treatment of the underlying cause, for example, if the patient is suffering from pericardial tuberculosis, in that case, after drawing the fluid out, we will have to start with the anti-tubercular medication and steroid. All right. Let's try to solve a question. Okay, let's solve this question. So, 65-year-old man is admitted to the emergency department with chest pain, nausea, and feeling lethargic. He has a history of type 1 diabetes mellitus, known to have CKD stage 4, secondary to the diabetic nephropathy. ECG was taken in the admission, shows widespread ST elevation. Blood test shows sodium is within normal. Potassium is 5.8, which is slightly on the higher range. Serum urea level is 26 and creatinine is 305, which is increased for a CKD patient. His renal function 1 month ago was showing, so both sodium potassium was within normal limit. You can see that the potassium level has increased. So there is features of hyperkalemia might be going on. Serum urea and creatinine both has increased over 1 month. So an echo shows a small effusion. What is the most appropriate next step in case of management? So basically, whether you go for oral colchicine or whether you go for pericardiectomy, pericardiocentesis, or IV corticosteroids or hemodialysis. So what should we do in terms of a small pericardial effusion? And a patient has obvious some CKD changes, which has worsened over 1 month. And there is widespread ST elevation. So in the ECG, it also shows pericardial effusion-like features. So what should be your, approach from here? The reason why they have mentioned colchicine is because in CKD patient, you cannot prescribe with NSAIDs. NSAID has anti-inflammatory property, and that's why NSAID steroids, these are usually used in terms of management of pericardial effusion. Any answer? Anyone who would like to try? Okay, as we just started, so I'm just not going to. So the reason why this is hemodialysis is because you have to understand this is a case of uremic pericarditis. So they have already mentioned this is a CKD patient with diabetic nephropathy, and there is no recent insult that is present, like there is no evidence of infection or anything like that. So most likely this is uremic pericarditis, and even though the potassium level is within normal level, we know that uremic pericarditis, uremic encephalopathy, these are usually the indication for going for dialysis or renal replacement therapy. So not only this is an indication for hemodialysis itself or dialysis itself, but at the same time, this is also the treatment of the underlying cause, so which we should be focusing on. So if you just go for IV oral colchicine or, like in IV corticosteroid, that will be basically symptomatic management. It will not really help the patient's underlying etiology. So, and pericardiectomy and pericardiocentesis is definitely not something that you should do when you get the, like a small effusion in the echocardiogram. So in that case, that leaves you with hemodialysis. All right. No, this one is quite easy. Okay, now in terms of the hypertension. So actually hypertension, we have been reading about hypertension ever since we were basically noobs, like from our medical undergraduation level, we have started reading about hypertension. So in terms of, MRCP part 1 specific point of view, you have to focus on, first of all, in management of the hypertension. Number 2, they're probably not going to give you scenarios with a very simple primary or essential hypertension management. Of course, it will be a little bit complicated, like patient might be having other comorbidities like diabetes or CKD or pregnancy, this type of profile. And second one is, apart from the management of hypertension, acute management of hypertension is very much important. Like whenever there is a target organ damage, or for example, malignant hypertension, management of malignant hypertension is very important for part 1 examination. Apart from that, if the patient with hypertension now has presented with hypertensive encephalopathy, or like flash pulmonary edema and so forth, or maybe like in fundoscopy there is evidence of papilloedema, or maybe they will give you like different thresholds, maybe 100/810 severe hypertension or malignant hypertension that is more than 200/130 millimeter mercury. So how would you like to, different types of scenario, this is actually more common, this type of management of hypertension. This is actually very important, four-star important topic. Number 3 is they will likely discuss about management of secondary hypertension. So the entire prompt will be giving you different types of STEM will require you to have different types of antihypertensive, but the ultimate treatment will be management of the secondary cause. If this is a secondary hypertension, management will always focus on the secondary cause. So treatment of the underlying cause, that is again a very important question that usually comes. And number 4 is when not to give treatment. So for example, in that case, your scenarios will usually involve like features like white coat hypertension, or sorry. Okay, white coat hypertension, or maybe your STEM will have like the ambulatory blood pressure monitoring, or home blood pressure monitoring less than target range. So it might be something like 130/80 or so forth, something like that. So these type of scenarios are very important to understand, and your answers will be different in each time. The more you practice, the more you will understand. So we will start with some basic concepts. Okay, so first of all, basic concepts are what are the secondary causes? Common secondary causes are the renal causes. So among the renal causes, we get glomerulonephritis, polycystic kidney disease or PKD, and renal artery stenosis, and or medullary sponge kidney, or maybe like glomerulosclerosis background. There are too many causes, CKD and blah blah blah. All of these will be the renal causes. Okay, among the endocrine causes, most of the endocrine cause actually leads to high blood pressure. The only one, the only endocrine cause that does not lead to high blood pressure, that is basically the Addison's disease. Apart from that, you'll see like Cushing syndrome, Conn syndrome, then acromegaly, both hypo and hyperthyroidism will cause high blood pressure. Previously, in our conventional, like ways, we used to know that hypothyroidism can cause isolated diastolic high blood pressure, and hyperthyroidism or thyrotoxicosis can cause isolated systolic hypertension. But in subsequent reading, I have found out that there is no like stony background to this information. So we'll just know that hypo and hyperthyroidism, both of these can cause high blood pressure. Then hyperparathyroidism, that can also cause high blood pressure. Then we have congenital adrenal insufficiency or congenital adrenal hypertrophy. So that can also lead to high blood pressure. At the same time, there are a couple of other metabolic conditions, for example, Liddle syndrome. It can also cause high blood pressure. So Liddle syndrome is basically defect in the renal distal convoluted tubule in the electrolyte channel. And just for the time being, it's important to know that Liddle syndrome usually causes metabolic alkalosis, and it causes high blood pressure, hypokalemic metabolic alkalosis. Okay, so these are some normal physiological conditions such as pregnancy. It can also cause high blood pressure. Some CVS causes, among those, coarctation of the aorta usually causes high blood pressure. Some of the drugs are culprit for secondary high blood pressure, that is NSAIDs, and steroids, OCP. So these are commonly prescribed drugs that can cause high blood pressure. Apart from that, MAO inhibitor or anti-Parkinsonism medication, that is monoamine oxidase inhibitor, that can also lead to hypertension. So in terms of diagnosing hypertension, so there is a specific term which I have used, white coat hypertension. So in one single clinic sitting, what happens is with the view of like wearing white coat or apron, by seeing the doctors, one patient might be agitated and thereby leading to hypertension. So this is not where you start with the high blood pressure. A patient might be, like agitated or stressed out. Patient has an impending surgery. Imagine a patient who is admitted for an elective procedure in the hospital, and 7 days before the operation, or the day before the operation, in a single reading, you find out that the patient is having blood pressure 160/100. So in that case, I have seen like lots of doctors even in our country who are actually quite renowned doctors. They will start with a low dose antihypertensive. This is not an indication for antihypertensive. What you need to do is you need to assure the patient and give probably the best medication you can give is anxiolytic. And you can postpone the date of the surgery, maybe 2 to 3 days, when the blood pressure comes down to a bit normal, or the patient has become a little bit more relaxed. In that case, you can go for an operation. But it does not mean that the PACO assessment which you did or the pre-anesthetic checkup that you did is not up to mark, or maybe the patient requires antihypertensive right away. Not really. Apart from that, white coat hypertension, which is why in order to, negate this type of dilemmas in terms of which patient we should treat, there are two terminologies that is widely used now. That is ambulatory blood pressure monitoring, or ABPM, and the other one is home blood pressure monitoring, or AHBPM. So ambulatory care is not really an ideal setup for our country, but this ambulatory care is widely available across the UK, across the NHS basically. So they can just walk up to the district level hospitals, or the district nurses can actually go to their, GP clinic, and or the specialized nurses who are responsible for monitoring this blood pressure solely. So what they do is like they will record the blood pressure monitoring 2 times a day. And 7 days this pressure will be monitored. So total 14 measurements are actually taken, and one measurement is taken at daytime after the patient wakes up, so usually around 8 a.m. right before the patient goes to bed, so usually around the 10:22 or maybe that is basically 8 p.m. So these two readings are taken, and then the average blood pressure is estimated from this 7 days reading. So this is how the ambulatory blood pressure is monitored. And what we usually practice in our country is the home blood pressure monitoring, because it's a lot of, we don't have the ambulatory clinic or, like GP clinics in our country. And we just tell the patient to, go to the nearest pharmacy or local pharmacy, or, if they have the digital blood pressure recording machine in their home. So within the home setting, in a very calm and quiet environment, a patient has to be in seated position, and the blood pressure is monitored, like very similar manner to the ambulatory blood pressure monitoring. But we can cut short this 7 days to 4 days in terms of the home blood pressure monitoring. So 4 days is minimum, but it's best to go for 7 days with 14 measurements in total. Usually the first day measurement is discarded, and then the average measurement is taken from the home blood pressure monitoring. The reason why I was discussing so much about these things is you'll see that the treatment options are slightly, the indication of when to start treatment, it's a little bit different. Okay. So in terms of the staging, stage 1 hypertension is basically 140/90. And but in a single sitting with 140/90 millimeter mercury, that does not warrant to start the antihypertensive management. So that's why subsequent ABPM, daytime average, or HBPM, daytime average BP, is considered to be more than 135/85. That is stage 1. So that is less than, like if you minus 5 millimeter mercury from each of the systolic and the diastolic, you will get the ABPM or the HBPM, stage 1 hypertension. And in stage 2 hypertension, this is 160 over 100. But in terms of the ABPM or HBPM, again, you have to just minus 5. But in case of the systolic, you have to minus 10. So it's 150 over 95. That is stage 2 hypertension. And in terms of severe hypertension, it is more than 180 over 110. So at any reading, like for example, a patient comes to you for the first time and you get the high blood pressure more than 180 over 110. In that case, you start with the treatment right away. So there is no basically indication of going for further ABPM or HBPM monitoring. But if the patient has come to you with a single, like blood pressure reading of both stage 1 and stage 2 hypertension, and patient has no target organ damage, no other 10-year, like cardiovascular mortality risk it is less than 10%, and no other comorbidities, in that case, you can just wait and watch and go for the ABPM or the HBPM strategy. So here, if the blood pressure single setting is more than 180 over 110, immediate treatment is usually considered. If there are signs of papilloedema, so that is basically one of the important target organ damage, or retinal hemorrhage, NICE recommends same-day treatment by a specialist. And if the underlying diagnosis is pheochromocytoma is suspected, for example, patient has diurnal variation of the high blood pressure or highly fluctuating high blood pressure, patient has alternating headache, palpitations, and sweating and all these things, in that case, you have to refer the patient to a specialist, that is endocrinologist. So ABPM, I have already discussed about the procedure. So how do we interpret the results? So if the patient has stage 1, according to the ABPM or the HBPM category, if the patient has stage 1 hypertension, that is, if the patient has more than 135 over 85, we only treat if the patient is less than 80 years of age, but there is a target organ damage evidence, or there is an established cardiovascular disease or renal disease, or patient has diabetes, or the 10-year cardiovascular risk is equivalent to 20% or greater. So in that case, we can go for treatment in a patient with ABPM or HBPM more than 135 over 85. That is stage 1 hypertension. If we get stage 2 hypertension, after doing the ambulatory or the home blood pressure monitoring for 7 days, and we get the stage 2 hypertension, in that case, we treat the patient with any antihypertensive or our choice of antihypertensive, regardless of the age. I hope you all understood what I tried to say. Basically, I used to remember it like severe hypertension, treatment, yes. Target organ damage, treatment, yes. Single setting hypertension, no risk factor, go for ABPM or HBPM. If ABPM, HBPM, stage 1 hypertension, see if the patient is having comorbidities or risk factors, or 10-year cardiovascular risk factor is more than 20% or equal. In that case, start with antihypertensive. And if the ABPM or the HBPM is stage 2, that is 150 over 95, in that case, start treatment. This is basically the summation of everything that I was just talking about right now. So here, let's try to solve some question. 71-year-old woman is reviewed in the fall clinic. Her blood pressure is 146 over 94. This is confirmed on a second reading. So in line with the recent NICE guideline, what is the most appropriate next step? So ask her to come back in 6 months for a blood pressure check. Arrange a 3 blood pressure check with the practice nurse over the next 2 weeks with medical review following. Arrange ambulatory blood pressure monitoring. Reassure her this is acceptable for her age. Start treatment with a calcium channel blocker. Which one is it?
Arrange for ambulatory blood pressure monitoring.
Okay, yes, very good. Patient age is less than 80 years. All right. So centrally acting antihypertensive is basically alpha-methyl dopa, which is commonly used during pregnancy. And we also have the clonidine and moxonidine. So these are basically alpha blockers or alpha adrenoceptor blockers. These particular medications are mainly used in refractory hypertension. So more than 3 antihypertensive with 1 diuretic that has been already used, but the blood pressure is not under control. In that case, we usually go for this type of centrally acting antihypertensive. So commonly this is seen in CKD patients or chronic kidney disease patients. In terms of patients with having diabetes mellitus, how do we go for management of hypertension? So you can see, like, if there is evidence of end organ damage, such as renal disease or retinopathy, in that case, the target blood pressure in a patient with diabetic individual should be less than 130 over 80 millimeter mercury. So that's also a little bit less than the, stage 1 hypertension. Otherwise, if there is no target organ damage, in that case, less than 140 by 80 is okay. But if the target organ damage is present, in that case, systolic blood pressure should be lower than 140. Sorry, 130. So our first choice of antihypertensive in diabetic individual with hypertension should be ACE inhibitor unless otherwise contraindicated. For example, obviously in a diabetic individual, if the patient has stage 5 CKD, in that case, you can't just go for ACE inhibitor. That will significantly increase hyperkalemia or fall in the GFR. So that's why, apart from that, you can, the first antihypertensive that you should choose for diabetic individuals should be the ACE inhibitors. But in diabetic individual, use of beta blocker, you have to be very cautious because beta blocker, along with thiazide diuretic, what it does is it can cause insulin resistance. And it can also cause, like, in hypoglycemia, our autonomic nervous system gets triggered, right? But with the concomitant use of beta blocker, it can actually dumb down the autonomic neuropathy normally. So that's why the autonomic response to the hypoglycemia can be masked because of the concomitant use of the beta blocker. So which is why, unless there is no obvious indication of using beta blocker, this is not the traditional antihypertensive we should choose for the management of hypertension in diabetic individuals. Okay. So let's try to solve this question. Next patient is a 74-year-old woman who's known to have type 2 diabetes mellitus. Her blood pressure has been borderline for a number of weeks now, but you have decided she would benefit from treatment. Her latest blood pressure is 146 over 88 millimeter mercury. HbA1c is 7.5%, and her BMI is 25 kg per meter square. So what is the most appropriate drug to prescribe here?
Ramipril.
Ramipril. Okay, very good. This is the ACE inhibitor. Just a second. So in terms of the malignant hypertension, so malignant hypertension, the blood pressure range is more than, systolic is more than 200 and the diastolic is more than 130. There is usually a target organ damage. So either in the form of papilloedema or retinal hemorrhage or vitreal hemorrhage, or exudative change, not exudative changes, but hemorrhage, retinal or vitreous hemorrhage. That is a common feature in the fundoscopy. Patient might be complicated due to the malignant hypertensive episode. Patient might be complicated with hypertensive encephalopathy or pulmonary flash pulmonary edema. So what are the symptoms of and here the patient might be also having acute kidney injury features as well for same reason. So normally in malignant hypertension, what happens, how the symptoms presents like depends on the organ that is usually involved. So for example, if the encephalopathy is present, in that case, patient will be features of like confusion, delirium, dizziness, all these things, or headache, severe headache. This is a very common presentation. Pulmonary edema will cause shortness of breath, chest pain, and acute kidney injury will present in fall or oliguria, anuria, something like that. Papillary edema, retinal hemorrhage, or vitreous hemorrhage will cause blurring of the vision. So, commonest symptom of malignant hypertension is basically severe headache and blurring of the vision. So these will be actually present concomitantly during a malignant hypertension episode. So how do you manage a case of malignant hypertension? How the management is basically, first of all, rest, admission, and but in terms of a malignant hypertension, you should keep it in mind that blood pressure should not, the diastolic blood pressure, it should not be less than 100 millimeter mercury in the first 12 to 24 hours. Same mechanism we use in terms of managing a hemorrhagic stroke. Because if the diastolic blood pressure is reduced rapidly in the first 12 to 24 hours, in that case, the cerebral pressure drops down and there is cerebral edema that takes place, which causes further damage to the brain. So apart from that, you should continue with the oral medication. Labetalol, IV labetalol is the main medicine that we usually prescribe. Sometimes atenolol can also be used like as in the oral form, but Labeta, IV Labeta is the commonly used medication. In some stems, you will see that it requires you to go for IV sodium nitroprusside. Depends on actually the stem or the context. For example, in severe bronchial asthma, you can't go for labetalol. In that case, sodium nitroprusside will be your treatment choice. All right, let's solve this 276 question. Dr. Nishanta, Dr. Nishanta, can you please try to take question 276 for me, please? Dr. Omar Haj. This is actually a very straightforward question, so anyone can take this. Dr. Tan Sing Ying.
Yes, ma'am. 56 years old man is emergency department, headache, chest pain, and confusion. His initial observation
I think, okay, Dr. Tan, how about I take the stem and
as nation, the pressure is conform and this is not
okay, Dr. Tan, for some reason, I think because of unstable internet, you're cutting off. So I will read the rest of the question. On examination, blood pressure is confirmed and equal in both arms. Blurring of the optic disc is also noted. He has no significant medical history and takes no regular medication. So what is the most suitable initial management? I think the answer is very straightforward here. Oral ramipril, IV phentolamine, venesection, IV nitroprusside, or IV hydralazine. Which one?
IV nitroprusside.
IV nitroprusside. Why? This is your answer? Because patient is having encephalopathy, right? There is evidence of headache and confusion. Patient is having malignant hypertension feature. So obviously in encephalopathy, you should go for centrally acting drug, that is IV nitroprusside or labetalol. Labetalol is not mentioned, so in that case, go for IV nitroprusside. Okay. All right. So Dr. Tan, if you're there, you can take the next question. Hopefully your internet will come back to normal by the time. All right. So Turner syndrome, previously I have mentioned that there are some of the chromosomal abnormality or genetic condition that is usually associated with cardiac abnormalities. So Turner syndrome is basically microdeletion of the one of the X chromosome. So that's why, because of lacking of an X chromosome, Turner females will not be having all the female features. So that is the phenotypic, presentation of a Turner syndrome. So what happens to the cardiac abnormality? In a Turner syndrome patient, actually, bicuspid aortic valve and coarctation of the aorta. So basically, left ventricular outflow tract abnormalities are predominant in Turner syndrome. So bicuspid aortic valve occurs in 15% of cases, and the coarctation of the aorta is 5 to 10% of the cases in Turner syndrome. And in terms of the coarctation of the aorta, so this is basically congenital narrowing of the descending aorta. If I just draw the diagram. So imagine this is the aorta. Okay. So this is where the coarctation or the narrowing is taking place. So if as the narrowing is in the descending artery or the descending aorta, so obviously the blood pressure in the upper limb and blood pressure in the lower limb will be different, and the blood pressure in the upper limb will be higher than in comparison to the blood pressure in the lower limb. Additionally, the pulse in the radial pulse and femoral pulse will not beat at the same time. It will be delayed. So that's why there is radiofemoral delay. Okay. So normally what happens is like when there is subclavian artery stenosis or supravalvular aortic stenosis, in that case, we usually take the blood pressure reading in two arms. If the two blood pressure difference is more than 20 millimeter mercury, so that is significant normally. So in upper limbs, you see that the blood pressures are almost equal, but in the lower limbs, the blood pressure is hugely different. Normally, we don't measure the blood pressure in the lower limbs. So if the blood pressure is hugely different, in that case, we should consider the diagnosis of coarctation of the aorta. So in terms of the coarctation of the aorta, there are some other abnormalities that you can see. Like, for example, along the aortic valve, you can see like a systolic click. And there is a systolic murmur, which is heard in the narrowed down aorta. The blood actually produces like a systolic murmur. So because of the gushing or the forceful blood movement across the stenosed aorta. So it produces a systolic murmur or thrill, and this is heard best in the dorsal scapular region. And in terms of the coarctation of the aorta, of course, surgical resection or stenting, these are the usual treatment modality. And patients might be present, initially with features of shortness of breath, chest pain, palpitations, and cyanosis of the feet that can often happen. In infantile period, they usually present with heart failure-like features. So notching of the inferior border, this is not typically that's happened in initial phase. It actually over the long period of time, because the blood pressure is not adequate in the lower limb. So in order to compensate for that, some collateral blood vessels actually originate. So because of those collateral blood vessels, it causes notching in the inferior border of the ribs. In the chest X-ray, this can be present, particularly in the posterior ribs, this notching is more prominent. This is not seen in the young children. So in later age or in adult patients, this type of notching can be seen. And coarctation of the aorta, we usually used to remember like in the chest X-ray, it looks like a figure of 3. Associations are, you can remember it like NBBT. So N is for neurofibromatosis, B is for Berry's aneurysm, B is for bicuspid aortic valve, and T is for Turner syndrome. So these are just random associations. Sometimes you need to remember this association because some questions will be like, which one of the, option is not associated with coarctation of the aorta? So here, exactly, least associated with coarctation of the aorta, the answer will be Prader-Willi syndrome. Isolated systolic hypertension, just want to mention one thing. The commonest cause behind isolated systolic hypertension is atherosclerosis. It's more common among the aged individual more than 70 years of age. And treatment protocol is very much similar to the normal hypertension management. So usually start with the ACE inhibitor, then a calcium channel blocker, then the thiazide diuretic and so forth, or the third antihypertensive drug. If the patient is Afro-Caribbean origin, in that case, we start with a calcium channel blocker, then with the addition of the ACE inhibitor and the diuretics and so forth. So this is how the management of isolated systolic hypertension should be like. Before 2011, normally in isolated systolic hypertension, thiazide diuretic was initially prescribed, but nowadays this has completely changed. So here you can see 74-year-old man presents to the medication review. Blood pressure is recorded as 184/72. So the systolic blood pressure is high only. This is confirmed on 2 further occasions. So what is the most appropriate first-line therapy? So there is no mention of Afro-Caribbean origin or anything like that. So the treatment will be
Amlodipine.
amlodipine. Okay, calcium channel blocker. Okay. So hypertension in pregnancy, in terms of the pregnancy, there are some individuals that have a more chances of hypertension or gestational hypertension developing apart from the other individuals. So one of these is maternal age, obesity, or high BMI. Maternal smoking that also causes increased chances of developing gestational hypertension. A family history that always plays a very significant role, one of the non-modifiable risk factor. Apart from that, hypertensive disease during previous pregnancy, and chronic kidney disease and autoimmune disease such as SLE, APS, and concomitant diabetes mellitus, like other comorbidity. So in that case, these high-risk groups can usually have like either gestational hypertension, preeclampsia, or eclampsia, this range of hypertension-related complications. Classification of hypertension in pregnancy is complicated. It varies. Remember, in normal, the pregnancy blood pressure usually falls in the first trimester. Because there is a change in the dynamic, like circulation, hyperdynamic circulation, and continues to fall until 20 to 24 weeks. So up until the beginning or initiation of the mid phase of the second trimester, blood pressure tends to keep on falling. And in the second trimester to up until the point of delivery, the blood pressure can be slightly higher level or normal. Hypertension is considered when the systolic blood pressure is more than 140 and the diastolic is more than 90, or increase above booking records of more than 30 millimeter mercury or more than 15 millimeter mercury. So that means like initially what happens is usually lean and thin patient or primipara, this type of women, they tend to have like a very blood pressure can be normally 90/60. In that case, imagine the patient's recorded or in the next visits you get 120 or 130 millimeter mercury and you discard it as a case of something that is not concerning. In that case, that would be wrong because the baseline blood pressure marking was, although quite low, for her the blood pressure is more than 30, that is the systolic, and if the diastolic is the rise from the base level is more than 15, in that case that can be categorized as hypertension. And normally gestational hypertension, it should be more than 20 weeks of gestation. But before the 20 weeks of gestation, it would be considered as pre-existing hypertension. And for preeclampsia, there has to be evidence of proteinuria. That is the main important point here. So proteinuria should be more than 0.3 gram in 24 hours. That is the urinary total protein excretion amount. And edema may occur, but edema can also be a feature of normal pregnancy at the same time. But remember that the pre-existing hypertension or the gestational hypertension, they will not have proteinuria, even though edema can be present, but proteinuria will not be a feature. And normally, pre-existing hypertension, the patient already on the antihypertensive medication, that should be continued. But if there is gestational hypertension, in that case, labetalol, calcium channel blocker, or non-teratogenic antihypertensive like methyl-dopa, that can be prescribed. And people with pregnancy-induced hypertension or gestational hypertension, they can have risk of further preeclampsia, eclampsia, or like IUGR, this type of complication if not treated well. Okay. Question number 285. A 36-year-old woman presents for a routine antenatal review. She is now 15 weeks pregnant. Her blood pressure in the clinic is 154/94 millimeter mercury. This is confirmed with ambulatory blood pressure monitoring. On reviewing the note, it appears that her blood pressure 4 weeks ago was 146/88 millimeter mercury. A urine dipstick shows normal. So there is no significant past medical history of any note. So how would you like to describe this? Any answer?
Yes. Yes, it is less than 20 weeks gestation. It is pre-existing hypertension.
White coat.
Okay. All right.
Pre-existing hypertension.
Pre-existing hypertension, very good. And the fact that there is confirmation that the ABPM has already been done, which shows similar findings, so we can rule out the possibility of white coat hypertension. Normal physiological change at 15-week would be if there is fall in the blood pressure. Rather, the blood pressure has increased. So in that case, this cannot be, belonging to the normal physiological change, and there is no evidence of proteinuria. So the answer will be pre-existing hypertension. Okay. So preeclampsia, like I've already mentioned, hypertension diagnosed after 20 weeks of gestation. Along with that, there is evidence of proteinuria. So that is more than 0.3 gram per 24 hour. And edema used to be a third element, but nowadays it is not included in the definition because, as I've already mentioned, pregnancy itself causes some fluid retention, and thereby edema can be considered as a normal physiological finding. So there are multiple problems that can arise from preeclampsia if it is not treated. That is fetal complication, prematurity, IUG or growth retardation. It can lead to eclampsia. That is in a preeclampsia patient now having complicated by seizure or hypertensive encephalopathy. That is known as eclampsia. And it can lead to also hemorrhage such as placental abruption, PPH, APH, these type of complication, intra-abdominal bleeding, intracerebral bleeding, cardiac failure, and multiple organ failure. So actually, you need to focus on the high risk factor, not much important on the moderate risk factor. So the high risk factors I've already mentioned, like these are the population that can usually have preeclampsia. That is, if there is previous hypertensive disease in a previous pregnancy, CKD, autoimmune disease, diabetes, and chronic hypertension. You can see that multiparity or 40 years, that is increasing maternal age, multiple pregnancy, BMI high, these are all considered to be moderate risk factors, family history. So severe preeclampsia, there are a couple of features. For example, if the blood pressure in a single setting is more than 170/110 millimeter mercury and proteinuria is 2+ or 3+, the patient is having symptoms, new symptoms like headache, blurring of the vision, abdominal pain, papilloedema, hyperreflexia, and platelet count is falling, that is less than 1 lakh, abnormal liver enzyme, or development of the HELLP syndrome. So HELLP syndrome is basically low platelet and high liver enzyme. So that is HELLP syndrome. So in that case, these are all considered to be signs of impending eclampsia or severe preeclampsia, very much similar. In that case, normally prophylactic magnesium sulfate is given. Management is antihypertensive is usually started. Oral labetalol is now the first line. Nifedipine and hydralazine may also be used, and delivery of the baby is the most important and definitive management step. So if the patient is, I have seen this in my practice, that if the baby is 32 or 33 weeks, something like that, but already has across the 28 weeks, then in that case, steroids are given to the mother, and then preparing the mother for an early delivery, either through elective cesarean section. That is the conventional thing that we practice in Bangladesh. Okay. So which one of the following is not a risk factor for development of preeclampsia? The answer should be
Smoking.
okay. Smoking. Yes, because carrying twins, smoking used to be a criteria, but I think this is not really a very important criteria mentioned in this bookish theory. All right. Okay, this one. Although the answer is showing, I would still like to discuss about this question, that is 289. 34 weeks pregnant woman is admitted to the obstetric ward. She has been monitored for the past few weeks due to pregnancy-induced hypertension, but now has been developed proteinuria. Her blood pressure is 162/94. So the first line medication should be here, labetalol. So this question actually came in the diet right after me. So that's why I just wanted to show this question. So that was actually a long time ago now, if you consider. So basically 2020 first diet, in that diet, this question came up. So which of the following clinical feature would be least consistent with the diagnosis of severe preeclampsia? The answer is option C, because hyperreflexia is a sign of severe preeclampsia. Least consistent. Why this is, I think this answer should be reflexes difficult to elicit, because hyperreflexia and clonus, these would be a sign of severe preeclampsia. Low platelet count, less than 100, that is considered to be, diagnosis of severe preeclampsia. I will talk about this thing because I'm pretty sure the answer is option C. So in terms of hypertension management, already have discussed about this. So basically, if a patient is less than 40 years of old, consider specialist referral to rule out the possibility of a secondary cause. In step 1 management, if the patient is less than 55, so that is basically less than 55 and more than 55. And if patient is less than 55, we start with ACE inhibitor. And if the patient is more than 55 or Afro-Caribbean origin, in that case, we start with calcium channel blocker, which I've already mentioned, like amlodipine was one of the STEM answers. In step 2, you add the A plus C, that is basically the step 2. In step 3, you have to add a diuretic. So in terms of the diuretic, actually indapamide among all the thiazide has the most antihypertensive property and least electrolyte imbalance causing drug. Okay. So in step 4 treatment, you have to consider adding a spironolactone or potassium sparing aldosterone receptor antagonist. So if the potassium is less than 4.5, in that case, add spironolactone 25 milligram once daily. If the potassium is more than 4.5, in that case, a higher dose thiazide-like diuretic treatment can be given. So if a further, say, even after giving all this medication, like A plus C plus D plus either spironolactone or higher dose thiazide diuretic, patient is pressure is not controlled, in that case, consider adding a centrally acting antihypertensive like moxonidine or maybe alpha methyl dopa or beta blocker that can be added. All right. Not this one. Okay, we will try to solve question number 293. Dr. Jana Prasad, can you please try to take question number 293? Okay, Dr. Shomendra.
Yes, ma'am. A 52-year-old man is seen in the hypertension clinic. He was diagnosed around 3 months ago and started on ramipril. This has been titrated up to 10 milligram OD, but his blood pressure remains around 156/92 millimeter mercury. What is the most appropriate next step in the management? Add benrofluothiazide, add bisoprolol, switch ramipril to peridoptil, add amlodipine, add losartan. Add a calcium channel blocker, man. Add amlodipine.
Okay, age is less than 55. In the
52.
regardless of that, it's already within the step 2 management criteria. Okay. Now let's try to solve this question. That is question number 294. So Dr. Shomendra has just taken this question. So Dr. Ananda, you can take this. Yeah.
A 60-year-old man is reviewed. His blood pressure is poorly controlled at 152 by 90, 80 millimeter Hg, and treatment with Ramipril 100 milligram BD,
10 milligram once daily.
10 milligram, Penroflumethiside 2.5 or milligram, and amlodipine 10 milligram OD. In addition to the antihypertensive, he also takes aspirin and simvastatin. His most recent blood tests show the following: sodium 139, potassium 4.2, urea 5.5, creatinine 98 micromillimole. What is the most appropriate change to his medication? Add furosemide, increase Ramipril to 420 milligram, add spironolactone, and add candestan, and add atenolol.
So what's your answer?
Beta blocker. As he's taking aspirin and simvastatin, it can be due to some cardiovascular something. So we can
So
add
which
some
one is your
atenolol.
answer? Yes. A, B, C, D, E. Which one?
Atenolol.
Sorry, I didn't get it.
Beta blocker, madam.
Okay, beta blocker. But you can see like the patient is already on ACE inhibitor and patient is already on thiazide and calcium channel blocker. So patient has already received step 3 management, right? So patient, in addition to the antihypertensive, he also takes aspirin and simvastatin. Most recent blood test. Okay, blood pressure is still not controlled. That is 152 by 90. Obviously, this is not controlled. Should be less than 140 over 90. So the potassium level is 4.2, so within normal limit. In that case, the next step should be adding a spironolactone, okay? Because that is the step 4 management now. So if the step 4 management was already exhausted, in that case, we would have gone for like a alpha blocker or beta blocker or something like that. Is that okay? We are not done with the step 4 yet. We can add another diuretic. Patient is already receiving thiazide and now the patient's potassium level is within normal limit, less than 4.5. So there is a room for adding a spironolactone. So we will start with a spironolactone. If the patient's potassium level was more than 4.5 millimole, in that case, instead of adding a spironolactone, we could have considered adding an atenolol. Is that okay?
Yeah.
Yep. Okay.
Thanks.
So I think there are 2 more, actually, let's see if it is mentioned here. Okay, yeah, this one. 79-year-old woman is reviewed. She has taken bedroflumethiside 2.5 milligram once daily for the past 10 years for hypertension. Her current blood pressure is 150 over 94. Clinical examination is otherwise unremarkable. An echo from 2 months ago is reported as ejection fraction 48%, moderate left ventricular hypertrophy, minimal mitral regurgitation is noted. So what is the most appropriate next step in the management? Should we go for increasing the bedroflumethiside to 5 milligram once daily? Should we stop the bedroflumethiside and start with a furosemide 40 milligram once daily? Should we add a Ramipril 1.25 milligram once daily? Should we stop the bedroflumethiside and start a Ramipril 1.25 milligram once daily? Or should we add an amlodipine 5 milligram once daily? This one is a little bit tricky, and I will tell you the answer a bit later. So anyone who can take a wild guess here.
Is it Ramipril 1.25 milligram OD?
So you want to continue the bedroflumethiside and then add the Ramipril. Is that correct?
Yes, yes. Because
Okay,
you have to correct the ejection fraction also, slow down the ejection fraction. ventricular hypertrophy is going on.
Okay, but the patient has not heart failure yet. He doesn't have any heart failure. Rather, he has left ventricular hypertrophy, which is probably a result of the uncontrolled hypertension. So okay, all right, I will take your answer. Anyone else who wants to consider like giving it a shot?
Because of the moderate left ventricular hypertrophy, they're adding ACE emitter and ACE inhibitors that will reduce the unnecessary angiogenesis and reduce the increasing of the ventricular hypertrophy.
Okay. All right. So you basically want to say that for remodeling purpose or cardiac protective activity, you want to start with the ramipril. Okay. So this is a little bit tricky answer because here you can see that patient already is a quite elderly woman, more than 55 years of old. And bedroflumetazide is already being taken for the past 10 years. So here, any option that requires you to stop the bedroflumetazide would be wrong. Because if you want to stop this particular medicine and start with a new medicine, that will lead to devastating complications, okay? It might even cause significant reduction in the ejection fraction, less than 40%, and provoke heart failure in this patient. So don't stop the bedroflumetazide right away. We usually have this kind of patients in our like clinic or settings normally. And here, I think the with additional concomitant use of bedroflumetazide, increasing the dose is not going to actually help her that much. So we need to consider taking a new medicine. So it's either option C or option E. However, why we're not considering amlodipine? Because amlodipine has no cardio, like remodeling property. So the cardio remodeling property, if there was, if the option B did not have stop bedroflumetazide and start furosemide 40 milligram once daily, that would have also been correct because not furosemide, maybe spironolactone. That would have been correct, okay? Because after that, I would have personally gone for either spironolactone or maybe an ACE inhibitor because both of these two medication, in the first class, I've mentioned that ACE inhibitor ARB, then the spironolactone, beta blocker, ivabradine, and combination of GTN and hydralazine. And another medication would be the sacubitril/valsartan combination. So they have the prognostic benefit. So if any option that says add those medication, you can go for that. Like any cardio remodeling property activity containing antihypertensive medication that can be added. So if the option was instead of ramipril, if they mentioned tablet spironolactone adding in a lowest dose possible, that would have also been correct. Okay, very good. Both of you are correct. There is another little bit difficult scenario. Okay, yeah, this one. 74-year-old woman is reviewed. She's recently had an ambulatory blood pressure monitoring that showed an average reading of 142/90. There is no significant past medical history of note other than hypothyroidism. Her 10-year cardiovascular risk score is 23%. So what is the most appropriate management here? Anyone? So the 10-year cardiovascular risk is more than 20%, right? Patient age is less than 80, but patient is more than 55 years of old. And ABPM confirms that blood pressure is on the higher end. So this patient requires antihypertensive. There is no, how do I say? There is no denying that. So there is no need to go for option C or option E. So either the option will be A, B, or option D. So which one?
Is it amlodipine? Start with amlodipine.
Start bedroflumetazide.
Yes.
Calcium channel block.
Okay, no, the amlodipine was correct because in age more than 55 or Afro-Caribbean region, we usually start with amlodipine tablet. There is no other, cardiovascular or any other comorbidities here. So that's why, amlodipine is basically the choice of antihypertensive. This is a very simple question according to the normal algorithm, but after, you see that after solving the complicated ones, once you start getting the normal question, your brain tricks you. So that's why I wanted to discuss this question. Okay, so basically there are two terminologies that I wanted to discuss with you. One is the resistant hypertension, and the other one is refractory hypertension. So if a patient is on 3 antihypertensive, and one of them being spironolactone, and still the blood pressure is over 114, then over 90, this is known as resistant hypertension. And refractory hypertension is if the patient is on 5 antihypertensive, 5 different types of antihypertensive medication, including a diuretic plus minus spironolactone. Still the patient's blood pressure is more than 140 over 90. This is known as the refractory hypertension. So actually in normal clinical practice, there is no virtual difference between the resistant and the refractory hypertension, because both of these conditions are normally seen in CKD patient management. So ultimately, we have to go for like an centrally acting antihypertensive or alpha blocker, something like that anyway. This is just for, like theoretical discussion I wanted to mention. Okay, how about we take like a 5 minutes of break? My throat is feeling a little extra itchy. After the 5 minutes break, I will be back. Okay, now we are actually coming to the second half of our remaining session. So we'll start with Takayama arthritis. Actually, this will be better described in the rheumatology section because this is a form of large vessel vasculitis. And vasculitis and other rheumatological conditions will be discussed within the connective tissue disorder. However, things you need to know, as there is like a large amount of cardiovascular complication that may arise from a patient suffering from Takayama arthritis, and it usually causes inflammation within the large blood vessel. That's why it has been incorporated within the cardiology section. So Takayama arthritis, it's basically large vessel vasculitis. It causes occlusion of the aorta, and question commonly refers to absence of the limb pulse. For example, if the inflammation of the aorta takes place in the subclavian region, so in the other hand, or in the affected arterial area or the territory, basically you'll get absence of the radial pulse or absence of the brachial pulse or something like that. So if the inflammation takes place a little bit distant to the descending aorta portion, in that case, you will get absence in the popliteal artery or femoral pulse absence or arteria dorsalis peris pulse absence, something like that. So more common in the female and reproductive age females, that is age between 15 to basically 45 years. In between that particular age group and among the Asian descendants, this particular disease is more common. Features are systemic features of vasculitis, that is fever, weight loss, generalized fatigue, or like malaise. These are quite common. Unequal blood pressure, you can see this is an important point in the upper limb, and evidence of carotid bruit. So what happens is if the subclavian arteries are basically inflamed, in that case, because of the abnormal blood flow, you will get some bruit. So in the carotid bruit, you can get this bruit. You can also get this type of bruit in the renal arteries as well. So renal arteries are nothing but like branches of descending abdominal aorta. So in the concomitant renal artery stenosis can also produce renal bruit as well. So carotid bruit is like more pathognomic or highly significant for Takayama arthritis. Intermittent claudication because of like abnormal blood supply. So when the blood supply gets cut off, particularly after like working for a bit. So remember that in peripheral vascular disease, what happens is that after walking for a certain distance, the pain starts. So similarly, if the hand pain is a common feature, particularly if it involves the subclavian region. The reason why I'm mentioning subclavian is so much because subclavian arteries are the most common branches of the aorta that gets affected in Takayama arthritis. So hand pain is a common feature here. And this particular hand pain is more pronounced after doing certain activities or raising the arms above the head level. that time this claudication pain usually starts or kick in. Aortic regurgitation among 20% individual, it can also happen. Associations are, it can be associated with the renal artery stenosis. Management in the form of steroids and immunosuppressant agents can be done. Sometimes some surgical steps such as, intraarterial stents or, arterial dissection, these are usually done, and end-to-end anastomosis that can also be. With extensive inflammation, what happens is with the help of steroid, this is not reversible. In that case, for example, gangrene has already taken place. So in that case, what happens is the disease portion of the artery is removed and the end-to-end anastomosis is done. And this type of large vessel vasculitis has a very high chance of thromboembolic manifestations or chances of, producing stroke, transient ischemic attack. In that case, in order to prevent that from happening, low-dose aspirin are usually initiated in this particular group. We will go to our next topic, that is aortic dissection. So aortic dissection is, it's a rare condition, but it causes severe chest pain. So according to the NHS UK protocol, in terms of a patient with central chest pain, there are 4 differentials that you always have to exclude. One is being the acute coronary syndrome. Second one is pulmonary embolism. Third one is the tension pneumothorax. And fourth one is the aortic dissection. So after you have excluded these 4 possibilities, you can proceed on to making some other differentials. So that's why aortic dissection is actually very important, because it's one of the devastating, rare, but a devastating medical emergency. Associations are, it can be associated with hypertension. Traumatic dissection can take place, bicuspid aortic valve, because in congenital anomalous arteries are obviously not as strong as the normal arteries. So that's why this dissection usually takes place. Collagen vascular disease such as Marfan syndrome, Ehlers-Danlos syndrome, because of the collagen deficiency, the tunica media and the intima, these are not proper, which can lead to dissection. Turner syndrome, Noonan syndrome, during pregnancy, because the gravid uterus puts pressure over the aorta and the inferior vena cava. So sometimes in certain individuals, the pregnancy can also cause tearing of the aorta. And syphilis. So syphilis can actually involve aortic valve, and subsequently it can cause some aortopathies at the same time. Chest pain typically severe. It usually goes through the back and tearing in nature. So this chest pain has a characteristic feature, that is, unlike the acute coronary syndrome, which usually radiates to the jaw or the shoulder, or sometimes left arm, this pain actually goes back to the back. So in abdomen, when we get like upper abdominal pain or epigastric pain that is going to the back, that is very suggestive of pancreatitis. Similarly, in central chest pain that is going to the back or radiating to the back, that is very, specific for aortic dissection. There might be aortic regurgitation, hypertension among the signs, and other features might be resulting from involvement of the specific arteries. For example, if the coronary arteries are involved, in that case, angina. If the spinal arteries are involved, in that case, paraplegia. And distal aorta, if it is involved, then limb ischemia can develop. Complication of a backward tear. Mainly complications are backward tear basically means that with the regurgitant blood volume, it is putting more pressure within the tunica media. So this can lead to aortic incompetence or regurgitation, and MI. Inferior pattern is often seen due to right coronary involvement. Complications are of the forward tear. This is unequal arm pulses and blood pressure. It can lead to stroke and renal failure. So these are from surgical aspect actually, but main complications are that it can lead to aortic regurgitation, it can lead to MI, and then unequal pulse or blood pressure in the arm and the legs. It can lead to, stroke and acute kidney injury. That is good enough. So, okay, actually, I've already shown the answer, but let's try to discuss this. 75-year-old female presents diaphoretic and distressed with new onset sternal chest pain radiating through to the back. So that's very specific for aortic dissection. As you can see, the pain is radiating to the back. She has a past history of hypertension, and she is on larcanidipine. So that's basically a form of calcium channel blocker. On examination, her blood pressure is 190/70, and there is an early diastolic murmur. Heart best at the left sternal edge. Her ECG is unremarkable. So early diastolic murmur in the left sternal edge, that is indicative of aortic regurgitation. What is the next best course of action? So here we have to confirm the diagnosis of aortic dissection. So which is why we can confirm it by going for a CT. Let's go through the option. One is aspirin or clopidogrel or IV heparin. Actually, in aortic dissection, going for blood thinning agent will be contraindicated. Cardiac catheterization, this is not a case of coronary syndrome, so cardiac catheterization is not that specific here. CT chest with contrast, okay, we can consider it. And urgent echocardiogram, actually, this is a bit non-specific for aortic dissection. Thrombolysis, not an indication right now. So as you can see, the patient is not having feature of ACS, rather feature of acute aortic dissection, has a background history of hypertension, aortic regurgitation, murmur, blood pressure is not controlled. So the diagnosis is definite from the stim. We get that from the history and examination. We are thinking this is a case of aortic dissection. And in order to confirm the diagnosis, we have to go with CT just with contrast. More specifically, CT angiogram of the aorta or aortogram, that is more specific investigation. So you can see that the IV contrast will be able to demonstrate the size and the extent of the false lumen. Which one of the following condition is most associated with aortic dissection? The answer should be bicuspid aortic valve. Okay. Aortic dissection in terms of management. Actually, in terms of management, Stanford classification is the more important one from medicine perspective. So there are basically two types, that is type A and type B. Type A involves the ascending aorta, and this is more common. You can see like in 2/3 of the cases, type A aortic dissection usually takes place. And type B or descending aorta dissection, this is a bit less common in comparison to the type A. And it occurs distal to the left subclavian origin, occurs in 1/3 of the cases. DeBakey classification is more used in terms of surgical management and for MRCS participants. So still we'll just go through it like a bit superficially. So type 1, there are three types, type 1 and type 2 and type 3, you can see. Type 1 usually originates in the ascending aorta, and it propagates to at least the aortic arch and possibly beyond it distally. Type 2 is originating in and it is confined to the ascending aorta only. And type 3 is originating in the descending aorta, rarely extends proximally, but it will extend distally. So type 3 is almost equal to the type B. Type 2 is within type A category. Only the type 1, it can sometimes extend up until the point little bit distant involvement is present in type 1. Again, it's quite difficult to, remember this type 1, type 2. The reason why they made this classification is because of the stenting or surgical correction, perception. So that's why we don't really remember the DeBakey classification. We usually go for the Stanford classification. In terms of a type A aortic dissection, which is limited to the ascending aorta, surgical management is required, but blood pressure should be controlled to a target systolic of 100 to 120 millimeter mercury before going for the surgery. And type B is mainly conservative management. So here, bed rest and reduction of the blood pressure, IV labetalol to prevent progression. That is the more important thing to do here. An intraluminal tear has formed a flap that can be clearly seen in the ascending aorta. I think there was a picture here. Anyway, they were just showing the type A and type B dissection here. I think for some reason, the picture has not showed up in this book. So complications, again, similar, I have already discussed this. Let's go through some of the questions here. 79-year-old man is referred to the acute medical unit following a fall. He is unsure why he collapsed, but he is now fully alert. He is complaining of abdominal pain, but his bowel habits are unchanged. He has a past medical history of prostatism and hypertension. He tells you he doesn't take any medication. Okay, on examination, he has a Glasgow coma score of 15, blood pressure 98/46, and a heart rate of 98 beats per minute. His hemoglobin level is 115. Platelet is normal, WBC count is normal. Radiology results are reported as chest PA film. Posterior anterior film shows lung fields are clear, widened mediastinum, abdomen is normal, bowel gas pattern. So which one of the following is the next most appropriate step in this man's management? Should we go for an urgent echo, CT aortic angiogram, start with IV labetalol, bronchoscopy with pleural biopsy, or pericardiocentesis? Okay. Let's look at the patient's prompt again. So refer to the following a fall. Okay, all right. So history of collapse is present. Complaining of abdominal pain. Yeah, okay, got it. So which one is the answer is, sorry. Okay, so CT
angiogram.
Yes, that is the more conclusive test to rule out the possibility of an aortic dissection. Most probably, this is a case of type B aortic dissection because type B aortic dissection usually causes abdominal pain rather than chest pain. Okay, question number 309. A 55-year-old man is admitted to the emergency department with tearing chest pain radiating through his back. Examination reveals the pulse is normal, blood pressure is borderline normal, saturation is 97% on room air. So everything is normal so far. Chest X-ray shows mediastinal widening. A CT shows dissection of the ascending aorta. So which one is the most suitable initial management? What is the answer?
Observe.
So is it type A or type B? We understand that this is a case of type A aortic dissection, right? And we know that when it involves the ascending aorta, usually surgical treatment is required. But we need to control the blood pressure before the surgical management, which is why the suitable initial management will be in the form of IV labetalol. So regardless, you see, like whether type A or type B, you need to, as a medicine specialist, you need to prescribe a patient with suspected aortic aneurysm. Sorry, aortic dissection is basically with IV labetalol. And if then you can go for, if it's an emergency, like if you confirm it with a CT or aortic angiogram or contrast CT with chest, CT chest with contrast, and you confirm this is a case of aortic dissection, you can just give IV labetalol. And whether you're not sure whether to go for surgical repair or not, you can form a multidisciplinary team and review the report with the surgical team or the cardiothoracic surgeon. Okay, so classification of the pulmonary hypertension is currently changing because of the terminology, idiopathic pulmonary arterial hypertension. The thing is, pulmonary hypertension and idiopathic primary arterial hypertension, these are not actually same. We know that, how do I say this? Idiopathic pulmonary arterial hypertension is a part of or form of pulmonary hypertension, but not all pulmonary hypertension is idiopathic pulmonary arterial hypertension. If you see the classification, you'll understand why. So primary pulmonary hypertension, now this is known as the idiopathic primary arterial hypertension. It has some of the categories. So that is, if the pulmonary arterial pressure is more than 25 millimeter at rest and more than 30 millimeter with exercise. So there is some sort of dynamic changes you can see. So primary pulmonary hypertension is diagnosed when no underlying cause can be found. So the name itself, you can see that this is primary pulmonary hypertension when there is no absolute cause behind it. And the secondary pulmonary hypertension usually has like other forms. For example, if there is a lung cause, if there is a cardiac cause, or if there is any thromboembolic causes. So in that case, that will be defined as a secondary pulmonary hypertension. Okay, so around 10% of the cases are familial, that is genetic predisposition is seen, that is autosomal dominant. And endothelin is thought to play a key role in the pathogenesis, which is why in the management of pulmonary hypertension, you see that we prescribe endothelin receptor antagonist. Normally in our country, we usually prescribe with the bosentan. Primary pulmonary hypertension, although there is no cause behind it, but there is some association. For example, HIV, cocaine, and anorexigens, that is fenfluramine. This is very important. I want you to, highlight this particular information because in some of the stems, you'll see this is going to be the only clue for a diagnosis of primary pulmonary hypertension. Because women who tend to be, they aspire to be models, they usually take different types of medications. Some women take thyroxine replacement. Some of them take, appetite suppressants. So fenfluramine is one of those appetite suppressants. And people taking fenfluramine for a long period of time or higher doses, they tend to usually be associated with high chances of pulmonary hypertension. So primary pulmonary hypertension is more common in the female, especially presents around 20 to 40 years. Progressive shortness of breath and cyanosis, these are the main features. And right ventricular signs of pulmonary hypertension. So signs of pulmonary hypertension will be basically evidence of right ventricular hypertrophy, then palpable P2 or loud P2, and then you can get raised JVP with prominent A waves and tricuspid regurgitation, Graham-Still murmur of pulmonary regurgitation. These can be present as a part of pulmonary hypertension. Investigation is echocardiography and right heart catheterization. Right heart catheterization is actually a more invasive test. So that's why not commonly done. Echocardiography is the first line investigation. Management is diuretic if there is concomitant right heart failure. To prevent complication, we can give anticoagulation, but mainly vasodilator therapy. So that is calcium channel blocker, IV prostaglandin, bosentan, which is endothelin 1 receptor antagonist, that is given. And heart-lung transplantation, you'll see that although this is pulmonary hypertension, only lung transplant will not be sufficient because the pulmonary veins or the pulmonary trunks are, completely connected to the heart. So in order to go for treatment of the primary pulmonary hypertension, you should go for double lung heart transplant. That's the only definitive management. So 37-year-old woman who was investigated for progressive shortness of breath is diagnosed with primary pulmonary hypertension and started on bosentan. So the mechanism of action of the bosentan is?
Endothelin receptor.
Yes. All right. So now the classification of pulmonary hypertension. According to the WHO, we have already established that pulmonary arterial pressure should be greater than 25 at rest or more than 30 after exercise. So the classification is group 1 is basically pulmonary arterial hypertension, IPA, or primary pulmonary hypertension with no cause. So it's basically idiopathic, familial, and associated with certain condition, which I mentioned before. You can see that sickle cell disease and pulmonary shunts, these are also some of the association. In group 2, the causes are basically heart causes. In group 3, you can write down lung causes. And group 4 will be thromboembolism. So group 1, there is no underlying cause. Group 2, heart cause. Group 3 is lung cause. And group 4 is thromboembolism. Group 5 is assorted or miscellaneous. I will come to that. In group 2, left heart diseases leading to pulmonary hypertension. For example, ASD, VSD, valvular heart diseases, and mitral stenosis, mitral regurgitation, all these things. Basically, any heart condition leading to subsequent development of pulmonary hypertension will belong to group 2. Group 3 is cor pulmonale, basically. So any lung condition or, like long-standing lung disease, such as COPD, interstitial lung disease, sleep apnea, high altitude, that can lead to pulmonary hypertension. That belongs to group 3. Group 4 is thromboembolism, mainly pulmonary embolism, you see. Pulmonary embolism leading to chronic pulmonary embolism, mainly that leading to hypertension. Group 5 is miscellaneous condition, that is lymphangiomyomatosis, secondary to the cancer or sarcoidosis. This can be within group 5. So this is very rare. So pulmonary arterial hypertension may be seen in each of the following conditions except What would be the answer here? It should be hepatitis B. Okay. Features I've already mentioned. Vasodilators. Okay, so all right, so this is a little bit advanced information here. Acute vasodilator testing. So this is actually done by the cardiologist in designated setting. What they do is like this can be done in either way, like there is an invasive way and there is a non-invasive way. So invasive way is basically going for a right heart catheterization and giving, through the guide wire, giving nitrous oxide, which acts as a vasodilator, and then to see the pulmonary reversibility challenge. This is known as pulmonary vessel reversibility challenge test. So if the histopathological show or the cross section shows that there is, or visibly there is, like pulmonary dilatation, in that case, this is said to be, like reversible changes. Or maybe that patient will benefit from the vasodilator therapy. But nowadays, instead of going for these invasive strategies, some non-invasive measures can be done, and acute vasodilator test is one of them. So acute vasodilator testing aims to decide whether which patients will show significant fall in the pulmonary arterial pressure following the administration of vasodilators such as IV prostaglandin, which is known as the epoprostenol, or inhaled nitric oxide. So if there is a positive response to this test, in that case, calcium channel blockers are added, like nifedipine. And if there is a negative response to the acute vasodilator testing, in that case, prostacyclin analogs such as iloprost, and in severe pulmonary hypertension, these are actually given. That's why in severe pulmonary hypertension, the vasodilator testing will be negative. Endothelin receptor antagonists such as bosentan, phosphodiesterase 5 inhibitors such as sildenafil, these are used. Although you probably know that the answer will be, of course, since we're talking about the pulmonary hypertension, the answer will be pulmonary hypertension. But the reason why I want to go through the STEM is how this type of STEMs can come for the diagnosis of pulmonary hypertension. You see, like this is a young age female investigated for increasing dyspnea and feeling generally weak and lethargic. Over the past few months, she has had 5 episodes of syncope, some of which occurred following exercise. There is no prior medical history of note, although her grandmother died at the age of 44 years after suffering increasing shortness of breath and syncope. This could be either primary pulmonary hypertension or it could be HOCM scenario. Now we'll go through the other remaining of the information. On examination, her oxygen saturation is 98% on room air and the pulse is normal. Second heart sound is loud, but no murmurs are heard. Auscultation of the chest is unremarkable. So in that case, all right. So here, just because there is a second heart sound that is loud, the answer should be pulmonary arterial hypertension, because in hypertrophic obstructive cardiomyopathy or arrhythmogenic right ventricular dysplasia, there should not be any loud second heart sound. So you see, like sometimes in a young age patient with collapse and no additional information and a positive family history, it could mean either familial or genetic cardiac arrhythmia, or it could be primary pulmonary arterial hypertension. But as this is a female patient, young age, and on examination, there is an obvious pulmonary hypertension related feature mentioned. In that case, the answer should be pulmonary arterial hypertension. Okay. Question 314. 44-year-old female is investigated for suspected idiopathic pulmonary hypertension. So that's basically group 1, pulmonary arterial hypertension. In that case, which one of the following tests is the best method for deciding upon management strategy? Is it serial echo, trial of calcium channel blocker, trial of endothelin receptor antagonist, genetic testing, or acute vasodilator testing? The answer should be, for management purpose, we usually go for acute vasodilator testing. If the testing is if the testing is positive, go for nifedipine. If the test is negative, in that case, go for bosentan prostacyclin or sildenafil. Okay. Okay, someone give me this answer. Let's see. Dr. Shomendra, can you take this question? 316.
A 60-year-old man is investigated for progressive shortness of breath. On examination, loud P2 is noted associated with the left parasternal.
Yes, left parasternal heave. ECG shows evidence of right ventricular strain and diagnosis of pulmonary hypertension is suspected. Which one of the following is the single most important test to confirm the diagnosis? Echocardiography, high-resolution CT, cardiac catheterization, pulmonary angiography, ventilation perfusion scan. Okay. So, sorry about the interruption. There was a technical glitch here. There was a net connection problem. So the answer is cardiac catheterization because they're asking to confirm the diagnosis. So cardiac catheterization or right heart catheterization, this is how you diagnose or confirm a case of pulmonary hypertension. But if it was like, what is the next best investigation? In that case, the answer would have been echocardiography. Pulmonary angiography and ventilation perfusion scan, these are actually more in line with, for example, not for pressure purpose, but if there's any interluminal defect within the pulmonary vessel. So most likely, if the underlying diagnosis was pulmonary embolism, in that case, CTPA or pulmonary angiography or VQ scan, these are usually done. But in order to assess the pressure within the pulmonary vessel, in that case, we usually go for like, first we start with an echo. And after that, in order to confirm, we go for a cardiac or right heart catheterization. Okay, Dr. Dr. Tan, if your internet has like better connection, you can take this case.
Okay, sure, ma'am. So female
okay, how about you just give me the answer? Okay, I will go through the steps.
Severe worsening shortness of breath, fatigue, and weight gain. No significant past medical history in particular. There is no
Okay, Dr. Tan, for some reason you're actually cutting. So let's see.
Central cyanosis and general edema.
Okay, all right. Chest radiograph shows cardiomegaly and dilatation of the pulmonary arteries, and echo suggests a raised pulmonary arterial pressure. Which one of the following is the mainstay treatment used for this condition? So is it betroflumetazide, aspirin, ramipril, prostacyclin, or bisoprolol? I think answer will be here. Prostacyclin. Okay, good. Hyperlipidemia. Okay. So first of all, you need to understand like what are the key elements that will help you understand whether this is a case of hypercholesterolemia or hypertriglyceridemia. Secondly, there are some specific skin manifestation or characteristic skin finding that will tell you which lipid abnormality that the patient has, which I will discuss one by one. So xanthomata, which is basically lipid deposition within the skin, this is seen in hyperlipidemia. This is generally present in all patients with any form of dyslipidemia. Palmar xanthoma. So basically in the palmar surface of the hands, you will see like some yellow depositions. This is more prominent in remnant hyperlipidemia. And less commonly, it can also be seen in familial hypercholesterolemia. Eruptive xanthoma, this is quite painful. So this occurs due to high triglyceride levels, and it can present as multiple red or yellow vesicles on the extensor surfaces. So these eruptive xanthomas are more predominantly occurring over the elbows and over the knee extensor surfaces, and they occur in like bunch or like clusters of grapes, and the term eruptive, that basically means it's quite painful. So here, causes of eruptive xanthoma, the first one would be familial hypertriglyceridemia, and the second one is lipoprotein lipase deficiency, but normally this indicates hyper TG levels. Tendon xanthoma or tuberous xanthoma or xanthelasma. So xanthelasma is seen around the eye area, or tendon xanthoma, this is seen over the Achilles tendon insertion, along the areas of tendon insertion, maybe along the wrist joint or along the ankle joint. And tuberous xanthoma, they look like a little bit linear like pattern. So that they indicate hypercholesterolemia and remnant hyperlipidemia. Okay, xanthelasma can sometimes be a patient with normal lipid profile. My own mother-in-law has xanthelasma, and her lipid profile have been completely normal, and she has no family history of any dyslipidemia. So management of corneal arcus. Corneal arcus is another feature of hypercholesterolemia, and sometimes it can also be leading to age-related or senile corneal arcus. So you'll see like most of these type of characteristic findings are in line with hypercholesterolemia, except for one thing, that is eruptive xanthoma. Only the eruptive xanthoma is a feature of hypertriglyceridemia. So management option for xanthelasmas are surgical excision. Then we can go for topical trichloroacetic acid and laser therapy and basically any form of laser operation can be done. These are all part of aesthetic surgical options. In exam purpose, eruptive xanthoma is the most commonly skin manifestation that usually comes. So the answer will be familial hypertriglyceridemia. So in terms of management, actually, there are two types of management. One is the primary prevention and the other one is secondary prevention. So primary prevention, patient does not have any cardiovascular, complication yet, but patient has other comorbidities, or maybe there are actually two different types of risk assessment scoring. One is according to the American guideline, which is the CRISC guideline, and the other one is the, there are a couple of other WHO and AHA guideline as well. There are so many actually different guidelines. CRISC guideline is the most commonly used guideline, which is used by the NICE recommendation as well. So people over 40 years of age who are likely to have a high risk of cardiovascular disease, defined as a 10-year cardiovascular disease risk factor 10% or greater. In that case, CRISC CVD risk assessment tool is used for patient less than 84 years, and patient more than 85 years, they are at high risk of CVD due to their age only. So CRISC 2 should not be used in the following situation, as there are more specific guidelines for these particular groups. That is in type 1 in diabetic individual, patients eGFR less than 60 milliliter per minute and or albuminuria. So CKD patients, diabetic patients, and patients with a family history of dyslipidemia. In that case, CRISC assessment tool is not used. And NICE strategy suggests that CRISC may underestimate the CVD risk in the following population group. So that is people treated for HIV. So what happens in people taking antiretroviral therapy, they can have lipid dystrophy or lipid abnormalities. People with serious mental health problem, people taking, so people who are already on antidepressant, which usually causes which tends to cause obesity. People taking medicine that can cause dyslipidemia, such as antipsychotic, corticosteroids, and immunosuppressant drug. People with autoimmune disorder, systemic inflammatory disorder, such as SLE. In these kind of groups of patients, CRISC tool cannot be used. And this is where CRISC tool cannot be used either. So if there is a familial condition, CKD, and type 1 diabetic individual. Apart from that, rest of the primary prevention who have like a high risk of cardiovascular risk, more than 10% or greater, but has not had yet an MI or stroke. In that case, as part of the primary prevention, you can prescribe a statin. I'm not actually going through the measuring lipid profile, just give it a go, it's quite easy. So normally for the primary prevention, atorvastatin 20 milligrams should be offered as a first line. This is important. In special situation, for example, in type 1 diabetic individual, consider statin treatment for primary prevention of CVD in all adults with type 1 diabetes. Atorvastatin 20 milligrams should be offered if type 1 diabetes who are older than 40 years, has had diabetes for more than 10 years, established nephropathy or diabetic nephropathy, and have other CVD risk factor. In that case, we should start with a statin. In CKD patients, atorvastatin 20 milligram can be offered to patients with CKD and increase the dose if a greater than 40% reduction in non-HDL cholesterol is not achieved and the eGFR is more than 30 ml per minute. Actually, statin is more toxic for the liver, not for the kidney. So as long as the patient does not have stage 5 CKD, you can increase the dose of the statin up until the point the patient has a lower cholesterol level, more than 40% reduction from the baseline. For secondary purpose, actually, all patients with, regardless of the age, gender, other comorbidity, whatever. In secondary prevention, we usually go for statin therapy anyway, because they usually have prognostic benefit and they prevent or slow down the already existing atherosclerotic process. And for secondary purpose, it's usually given in high doses, that is atorvastatin 80 milligram, but in like subcontinental region, our body threshold is not really suitable for such high dose atorvastatin. So we usually start with 40 milligram atorvastatin. Anyway, for exam purpose, you should remember 80 milligram. So in people, follow-up in a people who are started with atorvastatin should be followed up at least 3 months, and repeat a full lipid profile should be usually done in an empty stomach. So fasting lipid profile is superior than the non-fasting one. If the non-HDL cholesterol has not fallen by at least 40%, in that case, lifestyle changes should be discussed with the patient along with increasing the dose. NICE recommends we consider increasing the dose of atorvastatin up to 80 milligram. Lifestyle modification, so these are just, like nice to know type of situation, give it a read. So there are a couple of, in terms of eating and physical activity, a couple of changes that needs to be done. Moderate alcohol intake within social limits, smoking cessation. These are mainly the group of, advices you should consider giving a patient with hyperlipidemia. Sorry. So this is the main gist of whatever we have discussed so far. So you can see for primary prevention, people who haven't had CVD yet, but their 10-year CVD risk is more than 10% or equal. And with the exception of type 1 diabetes, CKD, or familial situations or hyperlipidemia situation, for primary prevention, we start with statin 20 milligram. And for secondary prevention, statin 80 milligram is advisable. So the reason why they're going for atorvastatin 80 milligram here is because patient has already suffered from acute coronary syndrome. So that is within secondary prevention strategy. Okay. So cardiac imaging, actually, it's not 100%, like just give it a read. There are a couple of like special imaging, which are more specific for research purpose or, like advanced, part of imaging techniques, not commonly done or routinely done. So among the nuclear imaging, radio, helium, technetium, and also the FDG or the which is used in the PET scan. This can be, like considered. MOGA and all these things, basically multi-gated acquisition scan, completely done for basically research purposes. Cardiac CT sometimes, on the other hand, this is something that we commonly sometimes do in the clinical settings, because cardiac CT actually, particularly the CT angiogram, it can be done in alternative to angiogram. People who has high chances of ischemic heart disease, but not fit to go for angiogram like traditional angiography, or in that case, or calcium scoring purposes, we can go for the CT, cardiac CT. So calcium score, you can see, there is known to be a correlation between the amount of atherosclerotic plaque calcium and the risk of future ischemic events. Cardiac CT can quantify the amount of calcium, producing a calcium score. And contrast enhanced CT scan allows the visualization of the coronary artery lumen. But bear in mind that stent insertion cannot be done obviously, because this is a non-invasive procedure. There is contrast-related complication, and this is not 100% specific. Unlike, of course, coronary angiography in the traditional way has a superior role in comparison to the CT angiogram. Cardiac MRI is mainly done in terms of diagnosis of cardiac amyloidosis, and the other one is arrhythmogenic right ventricular cardiomyopathy. In these two clinical settings, cardiac MRI is more commonly done. All right, let's try to solve this one. 79-year-old female presents to the low-risk chest pain clinic with intermittent substernal chest pain. The pain typically comes with exertion, improves with rest. A trial of GTN has been given by the GP, which helps with her pain. So this is an anginal pain. She is known ex-smoker of 30-pack years. She has no diabetes, hyperlipidemia, hypertension, and no family history of coronary artery disease. So basically no comorbidity, but the patient is an ex-smoker, not an active smoker at this moment. On examination, her observations are stable. On auscultation of her chest, her first and second heart sounds are audible with no added sound, and her lungs are clear. A pretest probability is calculated for coronary artery disease, which gives a result of 45%. So what is the most important investigation that's within like mild to moderate risk? So what is the most important investigation to pursue given her risk of coronary artery disease? Should we go for a stress test? Should we go for myocardial perfusion scintigraphy? No further investigations, coronary angiogram, or CT calcium scoring? Which one do you think should be done here? A 79-year-old woman will not be that much fit to go for like an ETT here, right? The answer it should be CT calcium. No, sorry, myocardial perfusion scintigraphy can be done because this will actually be more conclusive. Among these tests, no further investigation is wrong. Stress test ECG should not be done because of the age. Coronary angiogram will be invasive because the score is less. So it's either the option A or the option D. So the reason why they're preferring myocardial perfusion scintigraphy is they did not mention whether there is any availability issue. So in terms of positive predictive value, myocardial perfusion scintigraphy, this has a higher positive predictive value to the calcium scoring. So in that case, relatively less score, so less than 40% gray score, in that case, calcium scoring can be done. But as the patient is having mild to moderate, maybe moderate CVD risk factor, and that's why the myocardial perfusion scintigraphy, and because of the superiority, this one is actually taken. Okay. Okay, which one of the following radiotracer? No, that is an easy one, FDG. Which of the following non-invasive method provides the most accurate assessment of whether a patient has coronary artery disease? So now option A, contrast enhanced cardiac CT, cardiac MRI with gadolinium, exercise ECG, cardiac SPCT with reversibility study, and transesophageal echocardiography.
A, contrast enhanced cardiac CT.
Contrast enhanced cardiac CT because they are asking about the coronary artery disease. No, most accurate assessment of whether the patient is having, yeah, this one is the answer, okay. All right, so for syncope, okay, actually, let's have quite a free discussion. Syncope, the most common cause behind syncope is reflex syncope, okay? More than 40% cases of syncope is due to reflex syncope. So it can be either vasovagal, which is the common or the benign syncope. Basically, a glitch in the autonomic nervous system tends to cause fall in the cerebral blood pressure, thereby, and it has a couple of risk factors. For example, stress, anxiety, standing for too long a time, or maybe hot weather, or dehydration, sometimes skipping meals, or like vigorous activities, or even the sight of blood. This can trigger this vasovagal syncope. And the other one is a little bit known as situational syncope. So situational syncope is basically, it could be due to cough syncope, sneezing syncope, or it could be due to constipation, or basically in any strenuous activities. It can occur in even micturition syncope. So even during these activities, the patient has fallen to the ground or something like that. That is most likely situational syncope. Then we have the neurological causes or neurogenic syncope. Among the neurogenic syncope, number one cause is epilepsy. Number two is if there is any posterior circulation stroke. By posterior circulation, I mean if it involves the posterior cerebral artery, the vertebral artery, basilar artery, spinal artery, all these things. So posterior circulation stroke is another important cause of neurogenic syncope. And number three is it could be due to space occupying lesion, basically ICSOL or something like that. And there are a couple of other causes, but I'm not going to broadly go into the neurogenic causes because that will be discussed in the neurology section. Some metabolic causes of syncope. One of the commonest metabolic syncope is hypoglycemia, particularly in diabetic individuals. And if it is patient is having spontaneous hypoglycemia leading to syncope, first important thing to rule out is evidence of Addison's disease, and the other one is insulinoma. Our topic here is basically cardiac syncope. So how does a cardiac syncope feels like? Among the cardiac syncope, any type of cardiac arrhythmia is the main culprit. So it could be atrial fibrillation, it could be supraventricular tachycardia, it could be ventricular arrhythmias, it could be due to some congenital conditions or genetic diseases such as HOCM, ARVC, and all these things, long QT syndrome, etc. So these are basically the causes of cardiac syncope. The main difference between the neurogenic syncope and the cardiogenic syncope is, in terms of cardiac syncope, patient, it's very rapid. So it's a very rapid onset. It lasts for like maybe 1 to 2 minutes tops, and patient has a rapid recovery. And after this syncope episode, when the patient gains back his consciousness level, there is no residual deficit. So patient is not confused or anything. And during this syncope episode, or right before the syncope happens or takes place, patient might be experiencing palpitation, shortness of breath, chest pain, and so forth. Usually, cardiogenic syncope are brought on about by exercise or exertion in any form. On the other hand, in neurogenic syncope, it could be rapid to subacute onset, and it usually takes place minutes to hours. It can be, and after the patient has gained back consciousness, so the recovery is not really rapid. Recovery is not rapid, and after the patient has gained back consciousness level, patient is usually confused, or there might be some sort of focal deficit persisting, like in the form of arm weakness, slurring of the speech, headache, or like post-ictal amnesia, leg weakness, etc. And this is usually not related to activities. And cardiorespiratory complaints such as chest pain, or, like palpitation, shortness of breath. These are less common. Rather, neurological deficits such as slurring of the speech, hearing difficulty, vision problem, these are more common. And shaking of the limbs or the body, frothiness around the mouth, tongue biting, rolling of the eyeball, wetting, or like soiling the bed, those are actually more common in neurogenic syncope. Now we will go back to this one. Orthostatic syncope is basically when it is related to posture. For example, imagine a patient is dehydrated, or dehydration in anemia, severe blood loss, in Addison's disease when there is lack of cortisol, or diabetic autonomic neuropathy when the autonomic nervous system is not working properly. So after changing the position abruptly, for example, a patient was lying down and now the patient has stood up, or the patient was sitting and then now the patient is standing. So during this position change, the patient feels like there is a head rush and about to fall. That is known as the orthostatic syncope. So some of the causes behind orthostatic syncope is primary autonomic failure, which can be seen in Parkinson's disease and Lewy body dementia. Secondary autonomic failure can be seen in diabetic neuropathy, amyloidosis. Drug-induced, it could be due to diuretics, alcohol, vasodilator, ACE inhibitor, alpha blockers, and volume depletion, which can be a result of diarrhea, vomiting, that is dehydration, and blood loss or hemorrhage, etc. Okay, so in terms of evaluation, here this line is also quite important. So reflex syncope is most common cause in all age group. That is basically vasovagal syncope. And orthostatic and cardiac syncope, you can see these are actually becoming progressively more common among the older population. So how do we evaluate a patient with syncope? First of all, we have to go for a brief history, what the patient was doing. And before this syncope, whether the patient was standing for too long a time, what type of risk factor was present, whether the patient was doing any vigorous activity or anything like that, was there any concomitant chest pain, shortness of breath, any palpitation, any headache, any vision problem, any speech problem? Is it the first time the patient is suffering from this? What happened during that event? Whether the patient was completely unconscious, whether there was any epilepsy or any fit-like episodes, and how long did it last for? And after the patient has gained back consciousness or recovered from the syncope, now whether the patient was confused or disoriented, something like that. And was there any particular changes in the color? Because changes in the color can also be quite significant. If there is cyanosis, that usually goes in favor of cardiogenic syncope. And if the patient becomes flushed or reddened, in that case, it usually goes in the favor of vasovagal syncope. Actually, you have to finish all the systems and then you'll be in a better position to understand syncope well. And then during the time, whether the patient blood pressure and the blood sugar was recorded or not. And did the patient feel better after taking any glucose-containing drink? That will be usually indicative of hypoglycemia. And cardiovascular system examination. So this is also important. And cardiovascular and CNS examination, that is CNS and CVS examination. These are very important. You need to check for the postural blood pressure. That is, if the pressure difference in sitting and standing position is more than 20 in case of a systolic blood pressure and more than 10 in diastolic. So in that case, that is positive postural drop. You can go for ECG, Holter monitoring, carotid sinus massage. Tilt table test is mainly done for the vasovagal syncope, and 24-hour ECG, again, another name for Holter monitoring. And to visualize if there is any underlying structural heart disease, we can go for an echocardiogram as well. And to see if there is any stroke or space occupying lesion, you can go for any brain imaging like a CT or MRI. Okay. Lots of discussion will come if anyone wants to discuss about the syncope. But from cardiologic aspect, you have to know about the characteristic of cardiac syncope and the main causes behind cardiac syncope. So let's try to solve a question. 75-year-old woman is reviewed following a collapse yesterday. Her husband found her unconscious on the bathroom floor and describes her quickly coming round. Most likely cause of her collapse in this patient is, I'm not showing option E because the answer is within these options. What is the answer?
Reflex syncope.
Reflex syncope, okay. All right. So the main reason is behind, irrespective of the age, reflex syncope is more common. But if there is any cardiovascular risk factor that was mentioned, or maybe chest pain, palpitation, or something like that, in that case, cardiac syncope would have been the answer. Okay. Familial hypercholesterolemia. Okay. So remember that the CRISC primary prevention strategy I was mentioning about the in terms of there are 3 exceptions when you cannot go for the CRISC-2 tool assessment. This is one of the exceptions. That is a case of familial hypercholesterolemia or familial basically any genetic condition or familial condition. So it's an autosomal dominant condition and it's affecting around 1 in 500 population. So there is increased level of LDL cholesterol, and if untreated, it may lead to cardiovascular risk factors or stroke, MIs, things like that. So it is caused by genetic mutation encoding the LDL receptor protein. Clinical diagnosis is based on the Simon-Broom criteria. It's I always used to find it a bit difficult. So if the adult's total cholesterol is more than 7.5 millimole per liter, all of these levels are actually in fasting stage. And the load LDL cholesterol is more than 4.9. In case of children, not needed. You can just give it a read. For definitive familial hypercholesterolemia, if there is any skin manifestation, like either in the form of xanthelasma or maybe Palmer xanthoma or tendon xanthoma patient or first or second degree relative having these kind of conditions. And for possible familial hypercholesterolemia, family history of cardiovascular events in a young age, that is below 50 years, in second degree relative, or below age 60 in first degree relative, or any family history of raised cholesterol level that is positive familial hypercholesterolemia. So in terms of management, you have to refer to a specialist lipid clinic, and routine follow-up is needed here. Maximal dose of potent statins are usually required. So you cannot start with a 20 milligram atorvastatin. Higher doses are required in familial hypercholesterolemia. So first degree relatives have a 50% chance of having the disorder, should therefore be offered screening, even though the patient has a, like for example, if my mother or father, either of them had familial hypercholesterolemia, in that case, even if I have normal blood cholesterol level, I still would be, appointed in the genetic screening and also the occasional, lipid profile screening. This includes children who should be screened by the age of 10 years if there is one affected parent. Statin should be discontinued in women 3 months before conception due to the risk of congenital defects. So in that case, sometimes fibrates or dose adjustments, this can be done. Sometimes niacin, nicotinic acid derivatives that can be also given, but that is also teratogenic. So I'm not 100% sure on the pregnancy and hypercholesterolemia management. So hyperlipidemia management, here you can see that statins are HMG, CoA reductase inhibitor. This is the rate limiting enzyme responsible for the cholesterol metabolism. Adverse effects, myositis and deranged liver function test. This is the common adverse effect, which is why liver function test should be done in each of the visits after starting with the statin. Ezetimibe decreases the cholesterol absorption and it can cause headache. Nicotinic acid, it can cause flushing and myositis. Fibrates, on the other hand, can cause cholestasis or cholestatic jaundice and myositis, pruritus. Cholestyramine, it can lead to bile acid diarrhea, actually. Cholestyramine, it has GI side effect. Mainly diarrhea is a common complication. I think here they were mentioning about the eclampsia. Okay, not that you have to go extensively about the eclampsia, just the basics of it. So in a patient with preeclampsia now, developing seizure, that is known as eclampsia. And magnesium sulfate is used to prevent the seizure, as well as if a patient has already sustained seizure, we have to give the patient magnesium sulfate. So should be given once a decision to deliver has been made. Here, termination of pregnancy, once seizure has already taken place, in that case, there is no need to wait around for going for an elective cesarean section. You need to consider emergency cesarean section after controlling the seizure. In eclampsia, IV bolus dose of 4 gram of Maxalp is given over 5 to 10 minutes, and it should be given followed by an infusion of 1 gram per hour. 3 things are actually monitored, that is urine output, reflex, and respiratory rate, along with oxygen saturation should be monitored during the treatment. Treatment should be continued for 24 hours after the last seizure or the delivery, whichever is the latest. And other important aspects of treating severe preeclampsia or eclampsia include fluid restriction to avoid potentially serious consequences of fluid overload. Just go through this like very briefly. What are the normal physiological changes that take place in a patient with exercise? For example, the systolic blood pressure increases, diastolic decreases, thereby leading to the gap between the systolic and the diastolic increases. So the pulse pressure will be increased. In healthy young patients, there is increase in the mean arterial blood pressure, only slight. A cardiac output, increase in the cardiac output 3 to 5. You'll see that most of the things will actually increase during exercise, except for one, that is heart rate can also increase normally, but in athletes over the time, you'll see bradycardia. Okay. Apart from that, most of the things will actually increase. In terms of the exercise tolerance test or ETT, so basically risk stratification of the patient for myocardial infarction. Before going for what are the patients you should consider exercise tolerance test, there are 3 contraindications when you can't go for the exercise tolerance test. One is an acute coronary syndrome. During an active event or an acute event, you should not go for, particularly in the ST elevated MI, prescribe exercise tolerance test. Number 2 is severe or uncontrolled hypertension, and number 3 is severe aortic stenosis. In these 3 occasions, you should never advise a patient with ETT. Okay, basically risk stratification and non-ST elevated MI and assessing exercise tolerance. In those particular cases, ETT can be given, and it has a sensitivity of around 80% and a specificity of 70% of the ischemic heart disease. So here are the contraindication you can see. Myocardial infarction in less than 7 days ago. So in acute event, you can't go for that. In unstable angina, uncontrolled hypertension, aortic stenosis, mainly severe aortic stenosis. And if there is a left bundle branch block, so in these are the left bundle branch block and unstable angina are actually relative contraindication, but the other one is the absolute contraindication. So you should stop a procedure of ETT if the patient is developing hemodynamic instability, if there is any paradoxical fall in the blood pressure rather than increase in the blood pressure, and if there is severe and limiting chest pain, patient becomes exhausted or the patient requests, there is more than 3 millimeter ST depression, you should consider right away stopping the ETT. More than 2 millimeter ST elevation, stop if rapid ST elevation and pain. Systolic blood pressure goes very high, that is more than 230 millimeter mercury. And there is paradoxical fall of the systolic blood pressure more than 20. And attainment of the maximum predicted. If you already achieve the maximum predicted heart rate, which can be calculated using the ETT machine, so if you already achieved that, no need to go for further ETT test. Heart rate is falling more than 20% of the starting rate. And if the malignant arrhythmia, mainly VT or VF, if that develops, in that case, you have to stop ETT. So there are actually different types of scoring system for cardiology perspective. CHADVA scoring is usually done in terms of atrial fibrillation management and for consideration of anticoagulation mainly. ABCD2, it was previously used in terms of management for transient ischemic attack. It's no longer used now. NYHA classification of the scoring is basically for the symptomatic classification of heart failure patient, and not needed -28 now. Child-Pugh is for the CLD patient, not needed. Well score will be actually discussed thoroughly in the respiratory medicine because this is done in the management of pulmonary embolism or DVT. And Minimental scoring Okay, I think they have put all together all the scoring at the same time. Not needed. This is for cognitive impairment. HED is hospital anxiety and depression done by the psychiatrist, mainly done according to the Mental Health Act, to consider detainment of a patient during the hospital stay. Patient health question not needed. Cage questionnaire is for alcohol consumption or severity of the alcohol. Fast screening is done for initial stroke assessment. That is, F is for facial asymmetry, A is for arm weakness, S is for slur speech, and T is for time to response. CARB 65 is for pneumonia. Epworth sleepiness scale is actually done in terms of obstructive sleep apnea assessment. Apgar scoring done by the obstetricians. FRAX scoring will be discussed more in the rheumatology section because this is an osteoporotic risk assessment tool. Ransom criteria for acute pancreatitis mainly used by the surgeons. So for cardiology perspective, I think just focus on the CHADVA scoring and NYJ. That's it. So these medications actually, it will be more discussed in pharmacology section. So no need to worry about that. Just they have tried to put a separate section for the cardiovascular medication because sometimes 1 or 2 questions will come from the cardiovascular pharmacology only. So mainly for in terms of aspirin, what I want to mention is that aspirin is given in heart patients. In stroke or transient ischemic attack or peripheral vascular disease, clopidogrel is preferred over to aspirin. But if for some reason patient is intolerable to clopidogrel or insensitive to clopidogrel, in that case, you can go for a combination of aspirin and dipyridamole. And aspirin or ecosprin, that is given during MI or after an MI for prevention purposes. Like basically heart causes, aspirin is preferred. Ischemic heart disease, you can see this is the first line management. Aspirin potentiates the oral hypoglycemics, warfarin, and steroids. So you can see the one that I was mentioning is NICE now recommends clopidogrel as a first line following an ischemic stroke or for people with peripheral artery disease. Okay, dipyridamole, that's also an antiplatelet agent mainly used in combination with aspirin after a stroke or a transient ischemic attack. All right. Statin, they have prognostic benefit. Already discussed so much about the statin. Go through the adverse effects here. For example, it can cause all form of muscle disorder like myalgia, muscle pain, muscle tenderness, myositis, inflammation, rhabdomyolysis, asymptomatic raised muscle-specific creatine kinase. And more risk factors are people who already have like advancing age, female sex, low body mass index, and evidence of comorbidities such as diabetes mellitus. Liver impairment. So you should start with the LFT at baseline, and after 3 months and 12 months, this is how you should follow up with the ALT level. And if the treatment should be discontinued, if the serum ALT concentration rise and persist at 3 times the upper limit of the reference range. In our clinical practice, what we usually consider is if the patient is symptomatic, if the liver function is 3-folds than the upper limit, in that case, we have to stop. Or if the patient is asymptomatic, but the liver function, repeat liver function test has shown more than 5 times from the upper limit of the normal range, in that case, we consider stopping the statin. So some of the drug interaction, among the commonest drug interaction with the statin, you can see with macrolide antibiotic clarithromycin, it can cause further elevation in the creatinine kinase. So this question sometimes can come. And you'll see like grapefruit juice acts like a potent enzyme inhibitor. So it causes drug-drug interaction with statin and warfarin. So if a patient taking grapefruit juice, already taking statin, because of the enzyme inhibitor effect, you'll see that the statin-related side effects are taking more more prominently. Similarly with warfarin. So in a patient with warfarin and taking grapefruit juice, patient's complication will be different types of bleeding manifestation. The INR will be actually here high. Okay. Nicotinic acid, already mentioned, this can be given in patients with treatment for hyperlipidemia. All this use is limited by the side effects. Nicotinic acid, the way it is used is this is only the lipid lowering agent that also has a increased chance of increasing the level of HDL. So that's why it's still running in the market. And adverse effects are mainly flushing, myositis, and impaired glucose tolerance. In this particular scenario, you'll understand why nicotinic acid sometimes can be used. For example, 54-year-old man with a history of ischemic heart disease currently taking atorvastatin 40 milligram at night. Repeat lipid profile is shown. Total cholesterol is 3.9, HDL is 0.7, LDL is 2.6, and triglyceride is 1.2. What would be the most effective way of increasing the HDL level? So they want you to increase the HDL level. So the answer is add the nicotinic acid. So different types of alpha blockers are alpha-1 and alpha, or agonists blockers are basically alpha blocker, beta blocker, and non-selective blockers. So alpha blocker has alpha-1 and alpha-2 blockers. Alpha-1, that is doxazosin, prazosin. These are mainly used in the treatment of benign prostatic hyperplasia. They can be also used in terms of refractory hypertension management in CKD. Alpha-1A tamsulosin acts mainly on the urogenital tract, and alpha-2 yohimbine. Non-selective alpha blockers are phenoxybenzamine. This can be used in the treatment of pheochromocytoma. Beta antagonist, beta-1, you can see atenolol and bisoprolol and everything, and non-selective one is the propanolol, mainly used in the treatment of anxiety disorder, and beta-1 or selective beta blockers are mainly used in different types of cardiologic scenario or cardiac arrhythmia. Carvedilol and labetalol are mixed alpha and beta antagonist. Carvedilol is mainly used for heart failure management. Okay. So in terms of ACE inhibitor, we all know that the common side effects are dry cough. Another important side effect regarding the ACE inhibitor is it can potentiate the or complication of hereditary angioedema. So in your basic clinical science, you will read about certain immunological disorders where if there is a complement C1 esterase inhibitor deficiency in autosomal condition diseases, these patients tend to develop angioedema. So ACE inhibitor usually increases the level of bradykinin. So years after even stopping the ACE inhibitor, this remaining bradykinin can trigger the events of angioedema in people who are lacking the congenital C1 esterase inhibitor enzyme. So that is one of the complications. It can also lead to hyperkalemia. So that's why combination of ACE inhibitor and NBR is actually ARB, not really recommended. And postural hypertension or first dose hypertension can be, it's a possibility. And it also has teratogenic effects. Monitoring, okay, this one is a little bit important. So rise in the creatinine and potassium may be expected after starting the ACE inhibitor. Acceptable changes are increase in serum creatinine up to 30% from the baseline and increase in the potassium up to 5.5 millimole per liter. Calcium channel blocker, okay, so regarding the verapamil and diltiazem, they have myocardial depression or negative inotropic property. So that's why in patients with ventricular arrhythmia, verapamil, diltiazem, or like during heart failure, you should not be giving or prescribing verapamil and diltiazem. And it should not be given with beta blocker because it may cause heart block. And among these calcium channel blocker, verapamil also has an additional constipation as a side effect. Nifedipine and amlodipine, it usually causes ankle swelling as the most common side effect. Among the loop diuretics, okay, so for the loop diuretics, one of the complications are, apart from dehydration and electrolyte imbalance, it can also cause autotoxicity and renal impairment. Thiazide diuretic, hyperglycemia, these are more common in thiazide diuretics. So you see, like the thiazide diuretic, postural hypertension, gout, impaired glucose tolerance, and in male, infertility or impotence can be a complication. Spironolactone, it can cause gynecomastia and hyperkalemia. And for the sildenafil, important take-home messages: never prescribe a vasodilator with sildenafil. So this is mainly used in the management in premature ejaculation, and also this is used in the management of pulmonary hypertension. And contraindication of patient taking nitrates and related drugs such as nicorandil. A patient who already has hypotension, recent stroke or MI, and non-arteritic anterior ischemic optic neuropathy, which can be seen in GC or giant cell arteritis. Some of the side effects are visual disturbance, that is blue discoloration, and non-arteritic anterior ischemic neuropathy, nasal congestion, flushing, GI side effect, and headache. So in terms of heart failure patient, we already know that the medication that has prognostic benefits, but what are the medication you should never prescribe in a patient with heart failure? I'm sorry about that. So pioglitazone or rosiglitazone, so these anti-diabetic oral hypoglycemic agents should never be prescribed because they tend to cause fluid retention. Verapamil, it has negative inotropic effect. NSAIDs and glucocorticoids can cause fluid retention. And class 1 antiarrhythmics such as flecainide. So it basically any antiarrhythmic that can like prolong the action potential, that should be not used in patient with heart failure. However, amiodarone can be used. All right. So basically, that's about it. If there is any question, the reason why I did not go extensively regarding the cardiac pharmacology is because you will go through this information over and over again in the pharmacology section. Just give it a brief reading. I think you'll be good to go. Most of these are actually undergrad level discussion. So if you have any questions, please let me know. If not, thank you so much for the active participation. It was a very lengthy class. We had 4 sessions or 4 classes altogether for the cardiology discussion. Again, I would request you to put much more emphasis on cardiac arrhythmia, ischemic heart disease, and management of heart failure, and valvular heart disease, mainly focusing on the infective endocarditis, and then go through the remaining of the topics such as genetic conditions, as well as the cardiomyopathies. And today's discussion, pulmonary hypertension, systemic hypertension management. So these were the main important topics. Some questions can come from 1-star topic also. What is 1-star important topic? If it already comes to in your exam, that will be 5-star important topic for you. So never underestimate any topic. Go through all of these topics. Everything is quite straightforward. If you have any questions, you can let me know in the Doctor Academy Telegram channel. So till then, see you in the next class, hopefully. Till then, take care. Thank you.
Thank you, madam.
Thank you, madam.
Thank you, ma'am.
Welcome.